Maishani hell. Maishani hell.
The HIV epidemic has evolved since 1984 when the first case was diagnosed and went ahead to become one of the major causes of mortality, heaping a lot of pressure not just on the health sector but also the economy. It affected everyone, children, the youth, adults, both men and women. Now, it is this discussion that we focus on this edition of Maishani Health, where we continue highlighting the progress and achievements of universal health coverage as envisioned in the government's Big Four agenda. For this edition, we travel to the county of Kisumu. Let's now join my colleague Mutala Mukosia for more.
Kisumu, a vibrant port city on the shores of Lake Victoria. Apart from having one of the most beautiful views, it is one of the major commercial and industrial hubs in Kenya. Kisumu!
On today's show, we'll be talking to people on the streets of Kisumu town. We'll also bring you case studies on communicable diseases, including HIV. Later on, we'll host a panel of experts and wananchi to a town hall meeting to discuss more about the disease, as well as get a view from the Ministry of Health Command Center with the Cabinet Secretary.
At the time HIV and AIDS appeared in Kenya in the late 80s, it was feared as a terminal condition. But due to massive improvements in the public health systems, this is no longer the case.
My name is Doreen Akinyembudu.
Francis Akomo.
Doreen was born HIV positive, but got a confirmation testing at the age of 13. She started taking ARVs and has been open about her status. Her husband, Francis, a boda rider, is however HIV negative. Together they have two young and healthy boys, Meshach and Prince.
But then I was in class 6. I was very sick. My grandma took me to Rabur County Hospital. Opposite Rabur kuna VCT. They refused to test me because they were saying that I was young and they believed that HIV is transmitted through sexuality only. Mtoto alijua ngono wapi. Community health worker akakuja insist mtoto lazima tumsaidie. Being mamake alikufa, babake alikufa, lazima tumsaidie. Nikakuwa tested. Vile nilikuwa tested tu kuambiwa result, yani room ilikuwa being I was still young but niliona tu yani kitu ni real. Saa 2011 nilikuwa class 8. Nikitaka kumeza dawa naweka kwa karatasi ya PK yenye nakuja na nilikuwa mchoyo hata watu but hawakujua chenye na wanyima ni chenye hata siwezi wapea. Hadi ikafika mahali community pali sasa nilikuwa naishi town walijua. Francis ni bwanangu. Tulipatana 2015 vile nilimaliza form 4 sasa.
Tukaenda, tukakuwa advised, tukakuwa tested. Sasa mahali kizungumkuti ilikuwa after mimi nimerealize mimi niko negative, yeye yako positive. Tukarudi, sasa hapo ndo nilikuwa niendelee na huyu nifanye nini.
Baadaye kujua na kuaccept vile ilikuwa inaendelea. Nilifurahi sana, yani nilikuwa na furaha hadi na yani ilinipea courage ya kuadvise my youth wenzangu sasa. Juu sio lazima kuwe hivi ndio ukiwa hivi sio lazima upate mwenye ako hivi. Mimi wangu tuliconfirm hadi madaktari wa Russia waliconfirm ako sawa na ilini accept kwa sababu nilimwambia mapema.
Wale mabeshte wangu ukienda tu kupiga story ya hiyo kitu ati ule team ni mgonjwa, ukisikia yani discouragement, maneno yao ni ile ya kukuua roho. Na mimi kwa akili yangu niko huyo ako hivi, hii life itakuaje? Sasa mimi nilikuwa najaribu kabisa venye nitaficha hiyo maneno.
Saa baadaye kujua niko na mimba nikasema hapana. Hapa naye sasa ni kama nime infect huyu jamaa. Nikamuadvise tukaenda for test tena. Yeye akaniambia test ya nini? Sinajua hiyo kitu nimepata. Hata nataka tu nipeleke nifanyie vile walikufanyia wakakuweka kwa mada. Sasa nikamwambia pana, lazima ukuwe tested. Kukuwa tested akapatikana ako sawa. Tena tukapata huu mtoto wa pili, wameachana na kitu months. Kwenda kumtest baada ya tu ni hivyo. Mimi naye sasa nilifurahi, kumbe naweza fanya kitu na isinfect mtu. Hiyo tu ndio nilikuwa nafurahia.
Is treatment for communicable diseases in Kenya at par with global standards? Is treatment accessible to all Kenyans in every part of the nation? Is treatment for communicable diseases affordable?
Communicable diseases are infections that are passed from one individual to another in various ways. Could be airborne, could be waterborne, and could be direct contact with each other. And most of the communicable diseases we handle here, we have tuberculosis, we have cholera, HIV, the current COVID-19 that we're still having up to now, and we have other ones like typhoid. Yeah, of course, we've been handling a bigger number of HIV cases in Nyanza, and for now I can say a reprieve to the ARVs. We can see the number declining, and actually our hospital right now have put various measures in various places so that we make sure we don't let any patient who is HIV positive not linked to care.
We have three main interventions classification in terms of preventing new HIV infections, and that is biomedical interventions, structural interventions, and behavioral interventions.
The next step is that we must ensure that no child in Kenya is born with HIV. And that begins from the conversation of making sure that all adults that are of reproductive age have the information, they're empowered to make decisions around how to ensure that they do not infect their children if they are positive.
We found most of the percentage of the babies we get through mothers who are positive, the number has totally declined, and we are happy for such a success. We realize that most of our patients do not have these insurance covers. In the introduction of universal health coverage, most of our patients were benefiting a lot. Most of our patients were doing tests conveniently and it pays for them. They were doing x-rays, they were doing CT scans, MRIs. So NHIF is being rolled out at a very high rate in this hospital just because of the pending bills that at times they make the hospital not be able to get supplies.
Ingekuwa sasa ati budget yangu nimeweka hadi kwa budget ya kununua madawa. Ingekuwa maisha yangu ningeona tu kama iwezekani. Kwa sababu kwa ile Francis ni yule mwenye anafanya kazi na pesa yenye amepata kila siku hizo ndio za matumizi. Na yangu ile pia ni ile kidogo yenye at least inajaribu kuniweka busy. Yenye siweziweka ati sasa nilipie mtoto shule, nilipe rent, niweke kwa kununua dawa. Hapo na imenisaidia sana.
My husband died in 2005. After that, I started feeling sick, as if I had malaria. But every time I went to the hospital, I wasn't diagnosed with malaria. After a while, my joints started weakening, and it was even difficult to step down on my foot or even do anything. I decided to go to Lumumba Hospital, where I found a doctor whom we talked and asked me a few questions. My blood samples were tested and they found me with HIV. And that is when I started medication in 2005. My 3 daughters died of HIV because of ignorance. I told myself that I have struggled with you, so everybody to take care of their life. I was also taking care of mine. I even told them that I am an adult and I am taking my medication. What is preventing you from taking this medication? They refused. One thing I have noticed about my medication, they give me strength to do my task and I don't experience stress. So nowadays, I take 2 pills of my medication every morning, unlike back then where I used to take it both in the morning and evening, exactly at 7.
Thank you so much, Mom, for sharing with us your journey. Remember, the show is Maisha and Health. Thank you so much. Idinadhe, Mama. Asante. Doreen and Clary's stories are very encouraging. These are real stories of 2 strong women who are beneficiaries of quality and accessible healthcare. When one takes their ARVs as prescribed by the healthcare worker, one is able to live a longer and healthy life. Whereas antiretroviral drugs used to be so difficult to access, today one can access them at grassroots dispensaries. This has helped in the preventive measures against communicable diseases from early on. Odunga Market ndio tupo sasa hivi, yani Maisha ni Health. Tunazunguka tukiuliza Wakenya masuala kadha wa kadha kuhusiana na shughuli nzima ya afya. So kwa hivyo na mamangu hapa kidogo nataka kunisumbua kidogo. Mama, habari yako?
Poa sana.
Unaitwa nani mamangu?
Morena Uwar.
Mama Maureen. Sasa wacha nikuulize, ushaipata muda wa kujua hali yako ya HIV kwenda hospitali kujijua tu?
Hata last week but one.
Ni muda sijafanya hivyo.
Kwa kweli natamani lakini naogopa.
Ilikuwa February this year.
Nipita 3 months.
Sijafanya, si baada.
Nishajua.
Kwa hivyo ilikuwa lini wewe kwenda hospitali?
2 weeks ago.
Wachache wanaenda lakini wachache wengi waendi.
Na wewe mwenyewe binafsi ushaifanya hivyo?
Nimeshafanya.
Nini hasa kilikusukuma ukasema acha nenda nione hali yangu?
Vile maisha iko kuaminiana ninakuwa ngumu, lakini lazima ujue hali vile huko.
Yenye nilisukuma, niliona tu niende niangalie hali yangu venye iko.
Mama kwangu alikuwa ametoka. Sasa taswisi kidogo but vile aliamua kurudi nikaona tuende naye huko.
Nilienda na mke wangu tu hospitali nikaona nijipime mimi na yeye.
Asante. Kwa siku njema bro, nashukuru Haya, safi pale, kazi inaendelea, yani kazi mchanjo mzito, kitu babu kubwa yani. Tunazungumza tuna Wakenya hapa kuhusiana kama washaipata muda wa kuweza kujipima. Kumbuka show ni Maisha ni Health na mimi ni mtaalamu Kosia. The healthcare system does not discriminate or stigmatize where communicable diseases are concerned. Unlike other diseases, easily spread through a population. This is the one characteristic that makes communicable diseases a public threat due to the potential for mass infection.
Critical for us is to eliminate HIV-related stigma and discrimination. We know that people living with HIV in this country have been subjected to a lot of stigma. They are discriminated by people whom they love, and that is where we have to start from, because without that, then we'll never be able to ensure that they are also part of the conversation of supporting the response appropriately.
Stigma, this is just a state of one feeling of disgrace and have the fear of unknown in response to the experience which it could be internal or external.
By then, hapo nyuma, stigma ilikuwaga na watu, community, kama mimi sahi niko kwa bodaboda sector. Hapo nyuma yani mtu tu asikike ako positive. Hata watu walikuwa wanajaribu, unaona mtu anajaribu kukulenga, mtu akona perception ati ile nikienda niguze yeye hivi. Kitambo ulikuwa unaenda ukiambia mtu ati wife wangu ako hivi. But sasa ukienda uambie mtu ako hivi anakuuliza but anameza dawa. Kitu mtu anakuuliza anameza dawa, ukimwambia akwambia sawa.
Stigma will hinder this person not to do disclosure of the status. And when disclosure is not done, this person is going to infect the other person who does not know the status, especially during the sexual intercourse, which is unprotected. So that one will really fuel the infection to go higher and higher and the spread.
Back then, people were afraid to greet anyone with HIV because they thought they will be affected too. Nowadays, when one feels weak, they decide and even prescribe medication saying that it's just a normal virus or malaria. But when a doctor diagnosed you with HIV, it was a secret between you and the doctor. This reduced the stigma. And also, doctors gave them responsibilities of taking care of new HIV affected people, hence reduced stigmatization.
We as the people providing the services, we have incorporated those who are HIV positive into the service delivery so that they are involved. They are one of the biggest stakeholders in HIV care. So there is the peer and peer, interaction between these two people. The newly diagnosed with HIV and the one who was diagnosed and has overcome the stigma is now educating the other one.
Janet waka insist nikuwe kwa facility, nipewe job ya peer education. At least naweza saidia watu wengine. Na hivyo tu ndio nilianza kugain courage. Hadi una advice mtu hadi anasema, "Enyewe umenibadilishia maisha."
Motivator wangu mwenye amenitoa kwa hiyo kitu ni huyo Doreen. Yeye ndiye amenitoa kwa juu mimi sina yani hizo support group. Yeye unajua kuna hiyo access anaitwa training, anafanya nini. Mimi niko tu hapo. Yani hakuna mtu wa kuniongelesha. Sasa ni yeye akienda huko akuja aniongeleshe, anionyeshe, aniambie venye at least unaweza cope up na hii nini.
Maisha ni
Naam, katika kaunti ya Kisumu, yani Maisha Health, tunazidi kusonga mbele na kuuliza tu wakazi hapa kuhusiana na mambo ya discrimination na stigma kuhusiana na watu ambao wana virusi vya ukimwi. Kwa hivyo nazidi kutembea hapa Kisumu kuuliza watu kama wanahisi kuna ile kasumba na ile kutengwa kwa watu ambao wanaishi na virusi hivi. Kwa hivyo tunatembea hapa kuuliza kaka fulani hapa kidogo, nimuulize anaendeleaje na anaweza kupa maoni yake, anaweza tupa sisi maoni yake kuhusu na shughuli hiyo nzima. Habari bro?
Mzuri sana.
Unaitwa nani kaka?
Naitwa Davis Nyongesa.
Davis Nyongesa. Haya, sasa mimi nakuuliza. Unahisi kwamba kuna ile discrimination na stigma kwa watu ambao wanaishi na virusi vya ukimwi hapa kaunti ya Kisumu?
Na najua kuna discrimination sababu kwa hali nyingine ama nyingine kumeza hizo madawa mtu kwenda kuchukua pia inakuanga anaogopa. Na hata pia wenzake wanaweza kijua anameza dawa wataanza kumtenga.
Hiyo kama mtu ako na ugonjwa wa ukimwi hamfai kuacha. Mnakaa tu nao pamoja sababu ni ugonjwa tu kama malaria. Unakula vizuri, unapiga tizi na maisha lazima iendelee. Sasa ni kukaa pamoja kuwahimiza.
People who live with HIV wako na hiyo stigma ama they have that fear of disclosure. You get somebody is HIV positive, then hiyo time ya like anaogopa ata disclose aje kwa the family, the friends. Then atajiuliza, if I disclose my status, how will people see me?
Sasa hapo ni wenyewe tu wajitokeze, wakubali situation yenye wako nayo na wasiogope. Ni kitu yenye iko, wasiogope, wakubali situation na wameze madawa na waelimishe wenzao, itakuwa sawa.
Nashukuru sana ndugu yangu. Asante. Kwa na siku njema. Asante. Haya, pale umemsikiza mwenzangu pale akizungumzia hali nzima ambayo, na unajua leo tunazungumza kuhusiana na issue ama tuzungumzia swala kuu ambayo ni stigma na discrimination, yani kasumba, ukiritimba na kutengwa kwa watu ambao wanaishi na virusi vya ukimwi. Na kama njia gani ambazo zitatumika hasa kuondoa hizi kasumba, kuondoa hizi fikra, kuondoa hizi mambo ambayo hayaeleweki hasa kuhusiana na ugonjwa huu nzima wa ukimwi. Na pia tunazungumzia swala zima kama wenyeji wa hapa hivi ama wakazi wa hapa wanajua kwamba serikali inatoa matibabu kwa wagonjwa ambao ama watu ambao wanaishi na virusi hivi vya ukimwi. Kumbuka tuko kaunti ya Kisumu na show ni Maisha ni Health. Access to quality healthcare is a right enshrined in the 2010 Constitution. The healthcare system does not discriminate or stigmatize where communicable diseases are concerned.
The community health has improved during this period of UHC because we have, right at the community level, we are also having the community health volunteers who are given each households to take care of within their community units. So these ones, there is early identification of diseases, early identification of those children who have not completed their immunizations, early identification of women who are pregnant, early identification of the adolescents who are having gender-based violence while they are at home. So it has really improved, and prompt referrals to the facilities for further management.
Kisumu is the first county to adopt the community health information system. That is why the national government piloted the community health information system in Kisumu. All our community health volunteers, not all, 50% of them right now have been trained on a digital platform. And we have recorded almost 600,000 people in Kisumu out of a population of around 1.3 million into the digital platform. That means that our community health volunteers have visited half of the population. They have gotten all the data about them, all the data about their health, and this information now is in a database. So we have started with getting the foundation right, getting all the information about people right, and getting them from the level of their households. From then, it is easier for us to plan for them when you have all their health data. We want in future, when you are seen in, say, Jaramogi Referral Hospital, and we give you a clinic date to come back 3 months later, and you don't turn up, then your community health volunteer from your village should be able to be alerted that please follow up on such and such a kind of person, so that we don't have what we call silo systems. The future of health in Kisumu is moving to the level of the household, to the level of the person, to the level of the family, and to the level of the community. We are reversing the way we used to think about health as in a form of curative, people going into health facilities, to personal, to community, to household. And how we are doing that is we are seeing ourselves having a properly driven community health system in place. And when we talk about community health system, we're talking about the urban communities and the rural communities.
Communicable diseases, unlike other diseases, easily spread through a population. This is the one characteristic that makes communicable diseases very lethal.
Time now for a break. You're watching Maisha ni Health. After this, we'll be having a panel of experts to talk more on HIV and other communicable diseases. Welcome back. You're still watching Maisha ni Health. As promised, we have experts to discuss more about today's topic. The first case of HIV, the first diagnosis in Kenya, was made in 1984. 38 years today, 38 years later, we want to examine what progress has been made in as far as response and management of this disease. And now, we're just about to have a panel discussion with 3 experts who are tasked with handling this issue right at the grassroots level, right at the national level, in front of a live audience. Allow me to introduce my panelists now. On my immediate left, Dr. Ruth Laibon Masha. Dr. Masha is the CEO, National AIDS Control Council. She handles all the response mechanism under one unified authority, that's the National AIDS Control Council. Next to Dr. Masha, we do have Dr. Gregory Ganda. He is a County Executive Committee member, Health, Kisumu County. Karibu sana, Daktari. Thank you. And last but definitely not least, we do have Dr. Rose Wafula. She's the head of the National AIDS and STIs Control Program, otherwise known as NASCOP. Now, just to set the ball rolling, and we'll start with you, Dr. Masha, to give us an overview of where we are in as far as HIV management is concerned. Now, can you describe to us a historical perspective of HIV response in Kenya?
The story of HIV response and also the HIV itself is a story more of people who have been resilient. It's a story of commitment and a story of a hope that has kept people alive. We had around 200,000 cases of people dying every year. So the numbers of people dying were very, very high. So there was a lot of fear, stigma, and of course discrimination that followed. But what we saw is the government coming up, standing out, and then that's when the council then later was to be established in 1999. At the same time, science was also advancing across the world. I must say that Kenya, and Dr. Wafula can attest to this, Kenya has been one of the countries that has always moved with science in the response.
So over the years, from the 200,000 infections, we are talking about a 68% reduction in mortalities. So it's not as it was then. The numbers have drastically reduced. These outcomes has been achieved through increase in access to treatment, which we commonly call it ART. We've looked at an over 83% increase in ART coverage. Previously, we had about only 600,000 people being able to access treatment. Today, we have treatment for all, and that 83% is as a result of the change of that policy to that. Beyond just the ART, we've seen clients actually taking treatment well and getting virally suppressed. As a matter of fact, in the last population survey, about 90% of those who are on ART were actually virally suppressed. So even communities taking up interventions is something we've observed significantly changing across. In terms of subpopulations, which is one of the global indicators of success, mother-to-child transmission, as we know, if a woman is living with HIV, the risk of transmission to the child is high. We've moved from digits. The risk at the beginning of the epidemic was about 40 to 45% without any treatment. With treatment increment, currently in the country, you're talking about a 10.5% transmission rate. That is not where we want to go, but really, we know that the global indicator is less than 5%. We are headed there. So, but moving from double digits of highs and coming to about 10.5% means less number of children are being born with HIV, and then the burden that then continues throughout the years is reduced for our country.
Do you enjoy a similar kind of reduction in the number of HIV cases? And also share with us some of the success story in HIV response in Kisumu County alone.
Yes, thank you very much for that question. Yes, Kisumu has enjoyed the success that and contributes, of course, to the Kenya data that we are talking about. Back in the early 2000s, we only had one facility offering ART in Kisumu. That is many years after the national program started. And right now, we are talking about 145 facilities offering ART. So that is a tremendous improvement. 3,800 deaths in a year due to HIV and HIV-associated illnesses. And that has now reduced to 1,300 in the year 2021. So you can see a trend of reduction in number of deaths. You can see a trend in reduction in number of new HIV infections, which shows that as a program, we are really on the right track in improving the outcomes in terms of HIV.
A key issue is we must be able to find all the people with HIV and ensure they're on treatment. And we must ensure that we're all working together.
And you know, Kisumu is one of the counties which has a high prevalence of HIV. But what we've realized is that there seem to be other factors that people who have HIV, even when their viral loads are low and they're well controlled, they just have a higher risk of contracting cervical cancer. Secondly, their outcomes are not the same. Well, when we were in Eldoret, we did a study on patients who have same stages of cervical cancer, say stage 1A, 1B, early cervical cancer, which can have surgery. And you find that if you did the same surgery for the same stage of the patients, so those with HIV and those without HIV, in the next 5 years, you find the 5-year survival for those without HIV is higher. So you find that you have a 92% survival rate, that is cure rate, for those ones who don't have HIV. And if you come to those ones with HIV, it comes to 80%. So yes, the emerging trend right now, and even the mortalities that you're talking about, initially the mortalities were due to HIV itself. Now the mortalities are actually due to other causes or other related issues like cancer in those ones who have HIV.
Oh, interesting, and I'm sure our audience will have a lot of questions, especially with the correlation between cancer and HIV. But let's look at the numbers now. Because I look here at the statistics, and Kisumu County alone has about 124,000 people on treatment. And there are some who are still yet to be on treatment. 124,000, that's a huge number. Now, when you look at the cost of treatment, that's treatment alone. There are issues to do with management. There are other interventions that not necessarily have to do with medication, probably other interventions on protection and other issues to reduce the new infections. But now, 124,000, one county alone. How much does it cost to actually manage and respond to HIV epidemic?
Thank you. As you rightly mentioned, to quantify the cost of managing HIV, we have to be conscious that we can only do the most, because the cost at family, community level, the social cost, the mental cost of it cannot be quantified. And even when you're costing the commodities, it is just a fraction of what it takes to actually manage HIV, because you have the human resource, the infrastructure that goes with that. But over the years, the Ministry of Health with the stakeholders have worked together to annually cost what does it take to buy the commodities that are required to maintain the clients on treatment, to put those that require treatment who come in afresh, and to be able to test those who require testing to know their status. Averagely, in a year, it costs about 25.4 billion Kenya shillings for that component only of the response across the country. Per client who is on treatment, based on the current first-line treatment of HIV, it costs about $14 per year for one client, and that is just the ARV. Currently, the national guidelines also provide that we monitor and support clients to have an evidence-based response monitoring so that they know that the drug they are taking is good. And so those clients also require viral load, and those who fail treatment may require resistance testing. And so when you put all that cost, is about 25 billion for the country. And so for counties that therefore have a higher burden of these clients, the allocation of commodities will be higher. I know that Kisumu County, we are talking about the heights of over about 1.5 billion just for one county.
Just for HIV
For
response.
HIV alone, and not response, just the commodities.
Wow. Yeah. And now finally, Dr. Masha, because you are in charge of coordinating all this response to HIV, both at the national and at the grassroots level, I mean, when it comes to communication, because a lot of the communication probably in the initial years was around sexual transmission of the disease. How is the communication changing to aid in fighting stigma and to help people, to encourage more people to seek treatment and to maintain the treatment regimen as we wrap up?
Thank you very much. I think it's all be said, but basically something has been mentioned by Dr. Wafula. We all started with fear, stigma, death. And I think a lot of the media communication during that time was telling people, you'll get the disease, you'll die. So then the communication started from a negative perspective. And then over time, science evolves, options are more, people are living, getting grandchildren. And we now began slowly to change the narrative, but still we hadn't gotten it right. Until recently, in the discussion, she's saying that we then began to ask ourselves, what is wrong in the way we communicate? Are we communicating choices that people make for their own benefit and the benefit of the society? Are we communicating fear and moralization of the issue? So that is the narrative that has to change even from our side. What is it when you say peer education? We have been doing peer interpersonal communication for a long time. What have we been actually communicating through those interpersonal avenues? Is it the same fear, stigma, and death? Or can we shift the narrative to actually you have the agency to prevent disease, and we have the options available for you to prevent disease. And therefore, the change you're making is a positive change about how you approach disease. You don't have to fear it because you can be able to prevent.
Thank you, Dr. Masha, for that. And there you had it from the experts. And I'm sure because of what they said and the insights they've shared, you must have a lot of questions. We'll be fielding a number of questions from our audience here. Time now for another break. When we come back, we'll be getting questions from the audience to the panelists. Welcome back. Now, our audience here have a number of questions for the experts. Let's get them answered.
Cancer and HIV are somehow related, whereby a patient with HIV virus is at a high rate of getting the cancer disease. So my question is, for those who maybe don't know whether they have the cancer disease and at the same time they have the HIV disease, what are the measures that you take maybe to reach the person so that he or she can know that I have both the cancer disease and the HIV virus? Thank you.
As a country, I think the country has taken this very bold step to realize that the number of cancer cases is rising, and we need to do something about it. So what are we doing? We have to realize that there are two things. It's about prevention and early detection. Most of the time, most of the cancers, you will not be able to prevent. Most of the time, you will have to do early detection. So the preventable cancers, one of the big things that we have, of course, cervical cancer, we are giving immunization, HPV vaccine, to all young girls who are in school up to the age of 11. And I think that program has been rolled out by the National Cancer Control Program, which is also in Kisumu. We do it in primary schools and secondary schools so that we reach out to everyone. Sometimes we extend the age a little bit because then you don't have the numbers. And you still get the same kind of problems that should we get consent for a girl who is 10 who wants a HPV vaccine, or should we just go ahead and vaccinate them? So that is already being there. And of course, apart from HPV, there's hepatitis B vaccine, which is being given to all children to be able to look at the issues of hepatocellular carcinoma. What are we doing in terms of early detection in cervical cancer? Because that is the easiest thing that we can do, is that we have a yearly free HIV, cervical cancer, VIA villi or pap smear for our HIV population.
My question is, how soon shall we get the HIV vaccine in Kenya? Thank you.
Thank you very much. And this is a question you all keep asking. And unfortunately, I must admit that we do not have any vaccine candidate that is in the foreseeable future likely to be coming. But however, we know that with the developments we've had with the COVID vaccine, the world is now beginning to speak about using different technology.
My name is John Okoth, a youth peer provider at Maseno University. We always organize a condoms day at the university. So during that day, we sensitize our fellow comrades on the use of condoms, how they can prevent HIV and all sort of things. But later on, we are being judged as promoting immorality. So you as our heads, what are you doing to try and convince the religion that what you are doing here is not bad, but we are trying to help? Thank you very much.
At the National Risk Control Council, we ensure we bring all stakeholders, including religious leaders, in this conversation. But I must admit that in the public health space, we are in the space of saving lives. And the religious person is in the space of wanting to take somebody to heaven. So what we do best is that we ensure that person remains healthy, so the religious person can be able to talk to them and convert them to take them where they need to go. So we try to bring that conversation into a consensus that I have a job to do to make sure somebody remains healthy. And it's important that conversation keep up. And I must admit that we have a very vibrant group of religious leaders within the National Risk Control Council who are very progressive, and they see the fact that they need to save lives.
Joy, I hope your question has been answered. I think that was very extensive. Makofi kwa panelist tafadhali. Let's now get a view from the Ministry of Health Command Center with the Cabinet Secretary.
The story of the discordant couple at the beginning of the program is a classic example of how adequate information is key to decision-making, particularly to start a family and have a productive life despite being HIV positive. The audience in Kisumu primarily focused on stigma, shortage of HIV commodities, measures in place to mitigate against communicable diseases, the possibility of getting an HIV vaccine in the country, and how probably to promote the use of protection against HIV without attracting a moral debate. It is unfortunate that in this day and age, stigma towards patients with communicable diseases, not just HIV/AIDS, is still a matter of concern. Stigma and social exclusion are known to contribute to mental illnesses and other mental challenges. Therefore, we must continue to educate our people. Information is power. If well informed, we will eliminate the thinking that HIV is a curse or reserved for a specific group of people considered to have a low moral compass. In the last 9 years, AIDS-related deaths have reduced by 67%, from 58,000 to less than 20,000. This is attributed to an increase in the number of people receiving antiretroviral treatment, and those on ARVs increased to 83% from about 650,000 in 2013 to 1.1 million in 2021. The number of new HIV infections have also dropped by some 68.4%, from 101,000 in 2013 to about 32,000 in 2021. All these achievements are a testament to the deliberate efforts undertaken by the government. So, as we celebrate the success, we must not lose sight of the ball. And to build on these successes, we must put in place various strategies to deal with potential outbreaks of new communicable diseases, such as, for example, COVID-19 pandemic. As a country, we can end HIV as a public threat by 2030. But for that to happen, we must ensure zero children born with HIV in the country. We need to further diversify our funding options and to reduce the number of adolescents and young people getting infected with HIV, and also to ensure that those who are already infected have access to HIV treatment. And this is why I said we are lucky, because we are also wrapping up the local production of ARVs. And this creates confidence that even if we have got supply chain challenges, we will still be able to treat our people. We must approach efforts to address all communicable diseases with a preventive and elimination lens. There are countries that have eliminated HIV. Cuba is one of them. We must embrace the thinking that the greatest medicine of all is to teach people how not to need treatment. Hence, my clarion call: prevention, prevention, prevention. Maisha ni health, kwa hivyo chukua control.
You know, Mutala, for the longest time, stories around HIV have been about pain, suffering, and death. But I'm glad to see that there are so many stories which are uplifting, especially from Kisumu County.
Take, for example, the story of Doreen and Francis. This is a discordant, actually, couple that are very active in the society, especially in creating awareness on HIV and AIDS.
And these are exactly the kind of stories that we tell right here on Maisha ni Health. Remember, you don't always have to believe what you hear out there.
Believe only your eyes.
Yes, join us next week for yet another edition of Maisha
ni Health.
Nanena, leo nanena. Msikilize kwa makini. Ukimwi na korona, hivyo vyote ni virusi. Tusishindwe kuzuisha. Njia zote ni rahisi. Mikono situyaosha. Barakoa zingatieni. Usafi jambo muhimu popote tunapokuwa. Maisha tuyaringe. Hata wengine wakisita, nchi yetu tuyakinge. Tukuwe na umoja. Hali yetu tuyajenge. Usafi na maisha muhimu popote tunapokuwa. Shukran.
Maisha ni health. Maisha ni health.